Ladies and gentlemen, as I have already mentioned, we have gathered some of the most brilliant minds in the field to share their insights, their experiences, and groundbreaking work on how to manage complicated PCI cases. We believe it could be an excellent opportunity for interventionists to learn from each other. Welcome to the My Worst PCI Complications and Unforgettable Challenging PCI Cases. Before we begin, I'm pleased to introduce our chairmen and panelists for our last section. First, I would like to introduce the chairman of our section, Professor Dr. Phạm Mạnh Hùng, President of the Vietnam Society of Interventional Cardiology, Head of Vietnam National Heart Institute. Next, I would like to introduce our co-chairman, Associate Professor Dr. Hồ Thượng Dũng, Vice Director of Thống Nhất Hospital. And also I would like to introduce other important panelists. Please welcome Dr. Simon Loh from Malaysia. Dr. Lam Ho from Chuyên Môn Hospital, Hong Kong. And last but not least, Dr. Ngô Minh Hùng, Vice Head of Interventional Cardiology Department, Chợ Rẫy Hospital. Right. To begin of this session, please welcome Dr. Sozo Ishihara from Mimihara General Hospital to the stage and present the clinical cases. Please welcome.
Thank you for kind introduction. So I will talk about the very severe complication about during the CTO PCI. So I'm Shozo Ishihara from Japan, and so our hospital is in Osaka, and our hospital is very near from the Kansai Airport. As you know, Kansai Airport, we have direct flight from Hanoi or from Ho Chi Minh, so that maybe you can easily visit our hospital. Yes. So, as you know, when we do the CTO PCI, so we sometimes consider about the retrograde approach. This is a global algorithm of CTO, and it's okay. Yes. Now, can you see? Yes. So we can see the we can consider retrograde approach like this, and this is one case of retrograde approach doing so. So from collateral channel across the wire, and also like reverse cut of something procedure. And there are so many collateral channels, as you know, and septal channel is relatively safe, but epicardial channels, if we perforate, it's a very serious situation. And so complication during retrograde CTO PCI is a life-threatening complication. And also donor artery trouble, for example, RCA CTO, but left main or LAD problem, trouble, and or epicardial channel perforation induced fatal problem. So that we cannot experience many trouble cases. I have I don't have so many perforation cases, but so it is important to learn from others. So I will introduce one case. The patient was 66 years old male and stable angina, and he had the LAD CTO lesion, and we can see the collateral from RCA and from circumflex. And it showed quite viability in LAD lesion, and also ejection fraction is a little bit reduced. And for the viability, we decided to perform CTO PCI. But this case is not in our hospital, but other hospital. And so the young doctors who want to do CTO and want to learn CTO, so that I visit the hospital in Japan, and also I teach. And so young doctor try to do by himself for this CTO lesion. So this is a LED CTO like this. And also we can see the good collateral from RCA like this. This is a CTO distal part. This is a very good collateral channel, but unfortunately there is a strong bending point here. So we start PCI, double guiding system, antegrade 8 French and retrograde 7 French. And we discussed with local young doctor. And so he chose retrograde approach first. And first channel, he want to try RCA. And next step is circumflex. And third is septal surfing, because septal channel is unclear. So he start from RCA retrograde approach like this. We can see the good connection. And the vessel size is relatively enough big to cross the wire and also microcatheter. And so using calaveral microcatheter, and he tried to cross this bending part using SO03, very soft wire, and also calaveral microcatheter. But we can see microcatheter is moving like this with the patient heart beating like this. And the wire is coming here. In this point, so let's check contrast injection. I say, unfortunately, very severe perforation like this. And this is a collateral channel, so that blood flow is coming antegrade and retrograde. This is antegrade, retrograde, oh yeah, but so both bilateral side. So it's a problem. So at first, we quickly open up the balloon as a proximal part to stop bleeding with using 2O balloon. And so opposite side, we check. So we can see a little bit still bleeding, but I think it's acceptable. So that at this timing, change the operator from the young doctor and to me. And also, we gave up using this RCA channel. And so I start to retrograde from circumflex channel like this. And fortunately, the SO03 guide wire crossed the very tiny and bended channel like this. And the wire reached to the distal LED. Okay, I will show later. So this is a microcatheter, and also this is a wire. So fortunately, microcatheter reached to the CTO distal like this. And so we can see both so bilateral injection. After that, I advanced the wire from retrograde, ultimate velocity, XTA, and next gladius. And so after that, I advanced antegrade Gaia next to with the information of retrograde wire. So finally, I checked IVAS and also performed the reverse cut with using 2O balloon. So after that, retrograde wire can cross the CTO region, but unfortunately, the retrograde channel is too much long, so that a calaveral catheter cannot reach to the antegrade guiding. So that I advance one more guiding, so that RCA guiding, LCA guiding, and additional guiding. And so I advance the guide extension catheter, guide plus. So retrograde wire and microcatheter can insert into the third guiding catheter. Yes. And so we perform the externalization. And in this point, we check the bleeding. So after deflation, but still bleeding, still continue bleeding. Yes, so that, and after that, after deflates the balloon and checks the contrast, but so in this timing, so blood pressure drop down, and we should do pericardial synthesis and drainage. And after drainage, patient was stable, so that continue to perform the LED PCI. So after wire crossing, it's easy. 2O balloon dilation, 3O balloon, and non-compliant balloon dilation. And also put stent mid LED, and also after that, I want to check the bleeding, because if I put whole stent and I get the enough coronary flow of LED, maybe coronary perforation site will bleed more and more. So that I check, but still bleeding. So that antegradually, fortunately, I can cross the CTO region, so that I advance the microcatheter like this, and so put the coil here from LED side, like this. This is a one coil. The company is Cook, and so this is the second coil. But after putting coil, so antegradually or maybe bleeding is stopped, so that I start retrograde. So I put one more stent. After putting stent, but still bleeding like this. So in this point, I put the stent from RCA side like this. So bilateral coiling was performed like this. And check once again from RCA side, but still bleeding. We can compare. Still contrast is staining. So that in this point, I changed my mind. Not only coil, but I put the thrombus from the microcatheter. So we can get the thrombus easily from the puncture needle like this. So we get the thrombus, and so from the microcatheter I put, and so fortunately from RCA side we get the enough hemostasis, bleeding stop, and also LED side we check again with microcatheter, but unfortunately still bleeding. What we can do? Almost already thrombus was used, so that I get the fat tissue from the patient. We can cut the femoral puncture site and using like this small cutter, and I injected the small fat tissue at this point from microcatheter. So LED side also stop bleeding. And this side RCA, this side LED, CTO was opened, and also hemostasis was achieved. So this is the final result. It's an acceptable result. This is a case summary, 66 years old male, but procedure time is 6 hours. Very long time, starting from young doctors and change to me. And so stop bleeding is so much long time, yes. And so to stop hemostasis, to stop bleeding of channel perforation, we should detect the bleeding side. And also sometimes microcatheter wedge and also negative pressure is one option. And another one is, as I did, prolonged balloon inflation. Long-time balloon inflation, also important. And if we need, we do pericardial centesis. And also, another option is embolization. We should know coil, thrombus, and fat tissue or something, so that we should prepare this kind of embolization technique. And bilateral embolization, front side and also back side, should be considered when we face to the channel perforation. So this is a coil, so that we should just prepare just in case. So this is the last slide. Complication happens suddenly, and we should prepare bailout techniques and various options. And bilateral side hemostasis should be considered for severe perforation, and get used to various embolization. Thank you for your attention.
Thank you so much, Dr. Shozo Ishihara, for very interesting case. So may I ask our panelists, audience, have any comments or questions?
Thank you very much for your very exciting presentation. I think so. Actually, I also learned a lot from you because I am the also do the retrograde, but they very rarely use the epicardial cholesterol. So I just had a question for you that in this situation, when you first fell with the cross the epicard, so do you think that you will continue failing that you use the second? Because they already fell. So you use the circumflex to go to the distal LED, and then if that still ruptures, so how? So how to solve the problem? And in order to maintain the procedure quite long, about 6 hours.
Yeah.
So how to keep the ACT in order to maintain that still good coagulation and balancing between that and continuing doing the procedure? That's the key. I think the key point in this situation. Thank you.
Yes, it's a very important point. And so after preparation, we should consider about the ACT. Of course, so no preparation, we keep the ACT around 300 something during the CTO-PCI, especially retrograde approach. It's very important. But this kind of severe preparation, and we need pericardial drainage at that time. So it's very difficult. So in this time, so we keep the ACT around 200, around 200. And yes, it's one point. And also, so change from young doctor to for me. So I can't say I'm expert, I don't know, but so maybe I have enough experience for retrograde. So to help the patient at that time, maybe, of course, young doctor is difficult to do this kind of procedure. So that we change, but it depends on the situation. So young doctor also need the experience, but so rescue is more important. So.
Yeah, I think a very difficult case. Because when we do a rupture or bleeding from collateral vessel, it bleeding not only one way, it's a two-way. Yeah. From the donor vessel and from receiver vessel. So in this case, I think very, very, very difficult, very complicated case. You have the long way to close the bleeding. You use the coil, you use the prolonged balloon inflation in combination with the coil, which thrombus the embolism with the fat tissue. So I think I'm not experienced about the CTO-PCI, but I think the better way to avoid complications. Yeah.
I just add one more comment. On top of fat cord, nowadays I like to use wire cord. Just the absorbable wire, the suture wire. You cut it into pieces and then can push it through the microcavity. And then the wire cord can seal the perforation. Sometimes,
So as a coil, you use a wire, cut wire?
Absorbable suture wire. The wire cord. The wire that you use to do pacemaker or to do the suture. The suture wire.
Yeah.
And then you cut into small pieces and then you can fit it in.
I've never done, but it's a very nice option. Okay.
Interesting cases. But in my experience, sometimes we also use another tip to use the tip of the balloon. We cut the tip of the balloon and we push to block the perforations.
Wow.
Have you ever used that?
I have no experience of that. So okay, so maybe if it is a very distal, and so of course it may be one option. Oh, thank you.
Yeah, no more. For such a big channel, probably coil is still the best. Yeah.
Okay, thank you so much, Dr. Sojo.
Thank you so much.
Excellent presentation. The next speaker, we would like to invite Associate Professor Panipa Sunwanasom present the case second, case 2.
Okay, sorry. Thank you, Mr. Chairman, for your introduction. So, actually, I do not complication much because I don't do the complex one. I'm too lazy. But let's see that. I hope that will be something that interesting. So this is a man, 50 years old. So referred from the primary hospital because of non-STEMI. And really he spent his life in alcohol drinking and also the history of amphetamine use. So, as you can see from the echo that this patient has like EF just only 15% with the spontaneous echo contrast with the poor of RV and LV function for this case. And for the well, it's just like my MRTR. So at the beginning, because the patient came with the non-STEMI, okay, we take the patient for the coronary angiogram. So as you can see from the bifurcation of the, actually it's a trifurcation of the left main, as you can see this also here, with the shunt of the calcium. And in other view, so as you can see that we barely see the ostium of the LAD, of the left circumflex, and also the ostium of the intermediate, which is like have many view, and we cannot figure out that is there any disease in such ostium or not. So for the right coronary, it's quite okay, so just only a mild disease. Of course, because the patient got poor LV function, so we have to send the patient for the heart team meeting according to the national policy. If we are going to do the revascularization of the patient like that, we must have the document of the heart team meeting. So the surgeon say that, are you sure that the patient got the EF15 because the left main is that possible? The patient, the main problem is the alcohol. I say, yeah, I also think so because the patient is a heavy alcohol drinking, but do you dare to let the lesion with the 80% of the left main there? Okay, so the surgeon say, okay, so shall we do like this? We do the MRI and then we'll see that again. And they say that if there's just only a small area of ischemia, so we can do the medication or you just do the PCI with the stent across, fine. Okay, we send the patient for the CMI. As you can see, the LV function is poor, RV is poor. And the funny thing is that no evidence of relevant hypoperfusion, and the delay enhancement is negative for the late gadolinium enhancement. So, do you want to do anything with this patient? Stay with the medication, or you think that with the left main with 80% and this has to be fixed? So we bring the patient back for the heart team meeting number 2. So the heart team say that, okay, of course, we are not happy to let the patient live with this lesion as well. So maybe we just do like one stent, provisional, done. Yeah. So the plan for the procedure is like, okay, it's a trifurcation, but it's really difficult to figure out how many of the vessel have been involved. And because as you can see that we have a big chunk of calcium, okay, we'll stand by for the rotational atherectomy. And this is a really angulate LD takeoff. We plan to do this with just only provisional. Don't want to have any complex procedure because his EF is just only 15. Of course, it's going to imaging guide and hemodynamic because we don't have impeller in Thailand, so you have only ECMO or IABP. So the surgeon say that, okay, no problem, my sister. So I will have a VA ECMO standby for you. So if you need any help, just scream it. Okay, so let's see from for the pre-procedure. So as you can see, so there's a lot of color here, but as you can see that we have just the shot of calcified lesion here, and this is the opening of the intermediate, which is an angle is quite not the normal one, so it's quite tortuous. And as you can see that the ulcer that you see from the angiogram. So that's also contained of the attenuated plaque. So as you can see, everything is in the darkness. So it's not calcium, but it's just attenuated plaque. So talking about the calcium, of course, we have this just only if we have to think about whether we need a rotational atherectomy or not. Of course, this patient is just only one. So maybe we can manage with the cutting balloon. So as you can see here, so we use an NSE followed by the NCU fora, and then with the biometric, just only at the mid part. And then with the, actually for the NSE is prepared from the mid LAD up to the left main. And then this one has been re-dilated with the NC Aquaforce and the left salute integrity 4.0. So as you can see here, so the flow is quite okay, not bad. And then we do the part with the NCU for 5.0. And now we got a problem. So as you can see, before we do the port, the flow to the intermediate is quite okay. But after the port, where is my flow? And actually, as you can remember, that this intermediate is a really big branch. So the patient now develops chest pain. Hemodynamic stable because we already put the IVP up front. So at the beginning, it's like we try with the Y with the double lumen catheter with the Sasuke, but it cannot entry to the intermediate. So nitro, pot, anything I give. So with the double lumen catheter cannot pass to the opening of the intermediate. So what should I do? Because I'm not sure whether what happened, so I decide to do the pullback from the LAD to understand that what was happening at that time. So as you can see here, so actually the stent in the LAD is still not in the good expansion. So I think that, okay, I will do the post-dilation after I fix the problem with this intermediate. But as you can see that the intermediate, previously you see the very beautiful of the intermediate opening, but now I just see it like this. And then, as you can see, there's a discontinuation of the media around here. I'm not sure whether the problem that happened is because of hematoma, or is there anything that happened to intermediate because I do the port, or because I use an NSE to prepare the lesion, and then followed by port. So everything just like have a concealed perforation or not. So, and this is opening of the left circumflex, still okay. And as you can see here, that's the major malposition at the left main strut. Okay, so the problem is now I do everything. Already used double lumen catheter. I cannot wire. So at that time, I just thinking that, okay, we go back to the previous slide, and you see that actually it's good. I'm not sure whether to say good or not, but because we have a malposition here. So I think that even if I have to do some deformation of the left main stent, maybe I have to do that to create the way to go into the true lumen. So be it. So finally, I use the small balloon. So go under of the left main strut and then dilate it. Okay, I can go with some advance of the balloon there. And as you can see, the flow is quite more or less become better. So I get another wire and try to wire in to follow so this is in the 2 lumen with the Sasuke catheter, and try to follow the part of the previous one. Yeah, but as you can see, even I go there, the IVUS catheter cannot go, so the wire just can't go. So I decide to use a balloon, the small balloon again with the sapphire balloon. Oh, I already, so the time out, 0? Oh, sorry, time out. Okay, but anyway, so we go on. So IVUS is now entry to the intermediate branch. So I do the marking and checking whether I'm in a true lumen or not. So as you can see here, that of course I already used the balloon to distort the left main stent. So as you can see that this is the stent that I already distort from the round one, and then I have the wire here, and then Now you see the cause of the problem. The problem is because we have hematoma here. This volumen is true lumen, and it is a dissection of the osteo of the left main, which I consider that maybe happened during I did the NSC for the lesion preparation. So, so what I did is I used the NC to just open, because now I'm sure that I'm in the true lumen, right? So I use the NC to open the strut, and then I implant the stent. So this is not sure whether what to say, but it's going to be, I think, not sure whether I can say that it's a tap or not, because actually the angle is really not a tap at all. And then I do the kissing, and then do the kissing and port, and then I check again. So as you can see here, so this is the left main down to the mid LAD. So now you see that the strut like protrude in the left main, and this is the intermediate strut. So at the LAD, still I noticed that I have this under expansion, so I have to do the postulation in the mid LAD again. So now we go to the check of the intermediate. So the intermediate, as you can see, because the kissing has been done with the NC40 and with the stent. And as you can see with the stent, you cannot have the force enough to open the strut well. So as you can see, so if you stop without seeing this and think that you already do the kissing, this will be catastrophic, right? Because it's under expansion of the osteo intermediate stent. So finally, what I have to do is I do the kissing again with the NC both, and then do the imaging. So as you can see now, the opening is now become better. The intermediate opening is good. And so I think just only for this case, what I regret is, is that I still cannot fix the problem with this malapposition at the left main, because the vessel size is too big. So it's like 6-0, that we do not have a balloon to bigger like that, and especially the stent that we implant is just 4-0. I think no any stent in this world that can go to the 6-0 for the time being. So in this patient, because the strut is like floating in the left main, so I think that the patient should be in extended depth, at least, if allowed, that will be about 24 months. So the echo was done in the 6 months later, and the EF improved from 15% to 40%. And the medication that patient got is just ACI, spironolactone, beta blocker. That's it. So actually no fancy drug, no SGLT2, because it's the problem of the reimbursement. Yeah, but still we can see that the spontaneous echo contrast. He stopped smoking, stopped to use illicit drug, and also stopped drinking. So in this case, so as you can see that, of course, we have a dissection of the intermediate. You can notice that you use imaging to guide where is the correct way to go. Of course, if you cannot go with like conventional way, so maybe have to destroy your left main stent. But of course, you have to fix that later when you got the true lumen. And so as you can see, I was helped to confirm. And of course, this one has to be really careful if you do the oversizing. Otherwise, if you have a fracture, maybe that will cause the more problem afterwards. So thank you so much for listening. Any questions?
Thank you so much, Dr. Suwannaswamy, for very interesting case. So may I have a question to you? So if you had a chance to do again, so what would you may change your plan from the beginning? For example, you will protect the side brand with something like a crush technique or something like that.
Yeah. So actually, if I can turn back time, what I'm going to do is to check all the side branch with of course, because I'm already wired, but it's just like at that time, I don't know, I was like maybe ghost in my body that I don't think that I should check. But because you already wired and you already have an IVUS. So for me, if I can turn back time, I will do the IVUS, inspect all the branch, and then decide that again. Because I already know that I cannot see any osteo clearly. Yeah.
Thank you. Okay, thank you so much. So next speaker, I would like to invite Dr. Lam Ho for the third case.
Yes. Good evening, everyone. This is one of my most unforgettable complication case. Can we remove this one? Remove the timer. Yes. Okay. The patient's clinical history is very simple. A lady around 60 years old. She got very poor DM control. HbA1c was very high. She was admitted for ACS. ECG was non-specific. Echo good LV function. Troponin I was elevated. So we go to see the angiogram of the patient. This was the RSA. Nothing special. There's some lesion over the mid-RSA. Nothing special, right? Yeah. And then that's the left side angiogram. Do you see anything horrible? Can you see anything horrible? Of course, mid-AD, very tight ACS case. Anything horrible? Can you see anything horrible? I cannot see it, but there's one very horrible lesion over here. See it again. Can you see? No, nothing. Okay, another view. Can you see anything horrible? Is it just a usual ACS case with different view? Which part of the AD is the most terrible, most horrible? Which lesion is most horrible? Okay, nothing, right? So, as a usual practice, we just pedilate and then do the IFUS from very distal AD to the left main. Okay, this was the angiogram of the AD, and then we do the IFUS. Did you see anything horrible in the IFUS? So we start the IFUS from very distal AD. You can see very small vessel, many of lots of lesion, lots of plaque. Plaque burden was very heavy, but nothing special. It's just as usual. We know the plaque burden is heavy, lots of plaque. You know, there's an aneurysm. So we shortly will go to see. Probably we are somewhere over here. And then it's manual pullback. And then here is the aneurysm. So here is the aneurysm part. So further pullback is to see the lesion over here, over the proximal AD. So let's see. Okay. Do you see anything horrible? Okay, this is the left main. Okay, let's see again. So this is the aneurysm and then proximal AD part. Yeah, we also missed this. The fellow, of course, missed this. Can you see here? Actually, there's some fat. It's not OCT, it's IFUS, so you cannot see very clearly. Actually, there's a plaque rupture over here. And behind this lesion, let me show you again. Let me show you again. Can you see the fat? Can you see the plaque rupture? And then behind this lesion, why is so dark in color? It's not calcium. Calcium don't look like that. It's lipid, in fact. And it don't look like cord. It's actually lipid, very dark in color. In IFUS, in ultrasound, if it's calcium, it's bright in color, white. If it's very soft lipid, then it's very dark in color. So we see it again. So make sure everyone see it. So we can see here is the pulp rupture. So the most tight area may not be the culprit. The culprit is here, the proximal AD. And it's very dark and it's not calcium. So most likely it's lipid, very lipid rich. So just stand as usual, and then put one stand to the oxyl AD as usual. Nothing happened. And then see the time. I particularly show the time of the procedure. You see, it's 12. And then do the high pressure ballooning as usual. And then after that, 1 minute later, after the high pressure ballooning, while you do the high pressure on the lipid-rich part, you see, no flow in AD, no flow in circumflex. And the patient short. You can see the contrast stationary in aorta because BP drop. Why this will happen? Because it's a very lipid-rich part. You do the high pressure, and then it's not caught, it's the very soft oil lipid, and then the lipid go to distal, so AD no flow. You can imagine you squeeze your high pressure, and then the lipid go to the left main, and the blood continues flow from left main to AD, but your balloon was inflated, so it will push the lipid from left main to the circumflex. So both AD and circumflex no flow, just inflate. You see the time at once, no flow in AD and circumflex. Of course, my fellow give adrenaline, give adenosine, but no flow in AD insert arrest. Just a few minutes, no time to react, because the no refill by lipid is different from the no refill by cord, by air. It's different. Lipid is very oil, very sticky, and then it will block all the capillary. Most of the case need very long time to recover, and very difficult to manipulate. And most of the case, it will be refractory to your drug treatment. That's why sometimes you have no refill, you give drug treatment, but no effect. It's because most likely it's due to lipid-rich part and then induce no refill. So repeated adrenaline injection, everything, it seems okay. The patient's BP is stabilized a bit. You can see some movement. The flow in the circumflex was still slow. And then a few minutes later, of course, the patient still unstable, continue monitor and give drug to treat the no refill. Just a few minutes later, you can see the natural history of a lipid-rich part induced the no refill. Few minutes later, the blood is very poor, and you can see the circumflex flow still very slow. And then 1 minute later, despite all the treatment, you gain some flow, but it's gain some flow in the epicardial vessel, but the capillary are still full of oil. And 1 minute later, patient arrests again. What should you do now? What would you do? It's because in ECC I present one case, is no refill. We found that impeller is the last weapon and can help to treat the no refill. Because if you see arrest case, no refill case, you see the LV go like a ball, dilated, and the capillary pressure will be very high. If you put the impeller in, it suck the blood and then shrunken the LV. It can reduce the capillary pressure. At the same time, it produces a hemodynamic support, increase the pushing force, so that you can treat the no refill because you increase the pressure difference. So, but this is not evidence-based. In fact, impeller is very expensive. Do you dare to put it in while the patient on CPR, while push the heart? So after some discussion, we decided to do. And it's full recorded impeller instruction during CPR. We can show you, we can do it in 60 seconds. So You see the time, 12:30. After establish the vasa access, everything, and then we push the wire through the pigtail. Remember, use 5-inch pigtail. And then 6 seconds later, you can remove your pigtail. This is the impeller wire. But remember, continue to do the CPL. There's no hindrance for your CPL. You just do it, keep doing CPL. Make sure the patient don't have hypoxic brain. And then 60 seconds later, you can see. Continue to press the heart. Make sure the patient don't have hypoxic brain. When the impeller go into the aortic area, sometimes you will have some resistance, sometimes no. It's because the aortic valve will close while the patient's heart do not beat. So you just press the heart, open the aortic valve so that you can push the impeller in. So just 60 seconds, we put the impeller in. 60 seconds, 1 minute. And then start the impeller. Okay. And 10 minutes later, while the impeller keep function, keep the hemodynamic, and continue to give some drug, and the flow establish, the pulse improve a bit. So the flow restored, and the patient was safe, no hypoxic brain. So you see the full record, 1 minute, we finished the impeller. And this is restarted angiogram 2 months later. Now everything okay. So you can see so terrible for the lipid-rich part induced the no refill. So let's see the horrible things again. So now I think you will gain something, and next time if you see the part like this in IFAS, you will be very, very careful. Hot part rupture, you can see the fat. And then behind the fat, this dark color thing, soft lipid. It's a spectrum. Sometimes some lipid parts are not that horrible, but some are very liquid and very sticky and could be very horrible. But from angiogram, you really can see nothing terrible. You won't think here is the culprit. You may just stand from here to here. But in fact, the most terrible thing is over the proximal AD. And I can show you the ST, there's no acceleration, you just stand the distal part, it's not culprit, nothing happened. Stand the proximal AD, nothing happened. And only after the high pressure ballooning, after high pressure ballooning on the proximal AD, start to have acceleration, ST elevation after the ballooning. And then quickly the patient arrests. So, ask you this question again. Now can you see anything horrible from the angiogram? And that is the take-home message. Impeller can be as the last weapon for no refill. Stenosis is not equal to the hot culprit lesion. The most narrow part may not be the culprit. Be careful, no refill caused by lipid-rich part is another animal. It's different from the story you see before. Okay.
Yes, thank you so much, Dr. Lam Ho, with a very interesting case. Long way to manage the patient, but with the last result, very excellent. So, if you redo again this case at the beginning, what you do to avoid this complication?
Yeah, I think is to...
And maybe between IVERT and OCT, if you use OCT, what do you think might be different?
Yeah, for OCT, the first question, actually this complication can be avoided because you can just stand the proximal AD, you don't do the high pressure, give the patient statin, give PCSK9, and then restudy a few months later, and then do stand optimization. Then that can avoid this terrible complication. All this happens because you miss this lipid-rich part, and then you high pressure. and then it causes the problem. Or you look it down, you think it's a little thing, you just high pressure, and then it causes this problem. So how can identify is by angiogram. You can see that from this case is impossible. So only either by IFAS or OCT, both can be used to identify this situation. But for IFAS, you need more experience. Like this case, the fellow missed. For me, I read it again, I will also miss. Why I can see that is afterward. After the case, I reviewed the IFAS. I found that that is the problem. But for OCT, you can see the vulnerable part very clearly. That is 99% is IFAS better than OCT, but in this sort of situation, OCT can help you to visualize the vulnerable part more clearly than IFAS.
Dr. Lam, is it the hypothesis that the lipid pool is the hue at the proximal LED? Is it correct?
Yeah.
And the ulceration is just the hole that's when you go with a high pressure balloon, as it squeeze the lipid out from there to the distal end of the vessel and to the circumflex?
Well, there's a part, the balloon, high pressure balloon in phase. Of course, you squeeze some
squeeze the
emboli down. Of course, and on another way, it will also squeeze something to the left main, to the proximal part. But proximal part continues pressure from aorta, so it flush everything into the circumflex.
Yes, and in this situation, if you redo the procedure, so do we to stop that at that point of time, and then we use the high statin, dose of statin, or 1 or 2 months later, and come back and we do the procedure? Is it safer?
Yeah, if we do the procedure, we'll give prophylactic adenosine first, and then just put VO stent and go. And then we study a few months later, optimize a few months later.
Yeah, thank you so much.
Thank you, Dr. Sojo.
Yes, thank you so much. So I agree with you. So at that moment, so of course we can treat distal part of LED, but so proximal part, after checking IVAS, there is a so huge lipid-rich plaque. At that time, don't touch there. Is the most important thing. And after stabilization with lipid-reducing treatment, after that we can touch. And also, maybe, of course, IVAS can give us the very good information. But so maybe everybody cannot use IVAS because of the price of something. So that CT angiography also give me a very good suggestion about lipid-rich plaque. So that is this patient already done CT angiography? No.
We can't in Hong Kong. CT angiogram is a luxury.
I understand. So first of all, so treat LED, and after that, then high statin or PCSK9 or something, and later check CT angiography. Maybe it will give us more information, and also of course IVAS also important.
Yeah,
it's my comment. Thank you.
Very good suggestion. The important learning point is that impeller can be used to treat no refill, even the patients are in RS. And the second thing is to see the natural history of lipid which part induced no refill.
Okay, thank you so much, Dr. Lam Ho. And we would like to invite Dr. Simon Lee with the last case in this session. Lee? Simon Lee.
I feel very short here. I just make it. Thank you very much. When I landed in the airport, when it's about to land, and then the air stewardess make an announcement and said, ladies and gentlemen, we'll be landing in Phuket Airport. Did it happen to you, Dr. Lam Ho? The air stewardess, the captain said, we'll be landing in Phuket Airport. And I thought, how come I'm landing in Thailand, Phuket Island? But Luckily, when I got down, it didn't look like Phuket Airport. It's a much smaller airport. And it's my first time here. Anyway, thank you to Dr. Ang, Dr. Hui, for inviting me here. And good to see the old friends. I'm the last one to talk. I don't know whether my slides can be connected. Does it work? Actually, I feel very short standing here. Oh, mine is not strong enough. Sorry to hold you back. This is the last case. Yeah, but I think after Dr. Lam Ho's case, sorry I didn't see anything of your case. I was, I asked the driver to drive a bit faster, but the speed limit is 60 kilometers an hour from the airport. And I have to pay the fine or the summons. I told the driver, Dr. Ang can pay, but he refused to drive faster. Oh, I entered my password. Oh, goodness. Now I can see you better. Hang on, I have to go here. I am on this lecture mode. Oh, next one. Still cannot? You copy? Still cannot. There are only 2 ports. Copy? Yeah? Mm-hmm. Yeah. I will show you which folder. Can the panelists keep talking whilst I go and fix this problem? I think I have to download. Cannot use my own laptop.
Oh. I think why I did not make any comments on Ishihara's case. In fact, it's very difficult to make better management than his management on the preparation. In fact, that's a very classical and very educational case. Try to remember this case because it could happen while you handle epicardial channel, while you're doing retrograde CTO epicardial channel. This is the most terrible situation. That is the things that I want to say, and always learn a lot from his case. And for the closure of the Weymouth case, for bifurcation, sometimes really difficult to predict. There are 2 situations that will make things very unpredictable. One is calcium, one is fungus. I found that most of the time you can predict the bifurcation will close or not, or you can predict everything 99% correct. But if in the bifurcation you see fungus and calcium, these 2 things will make things very unpredictable. Sometimes even very simple case, simple lesion, it will also close. And that is my previous painful experience. So when I see calcium and fungus, my first hold to do more maneuver, including upfront 2 stand, is lower. My threshold to do more maneuver will be lower once I see calcium and fungus in bifurcation. Yeah.
So I have a question for Dr. Lam. Yes, I have a question for you. So, what do you think? What we can do if we have another same situation that we have a very rich lipid lesions? We can see on the iris. Should we do like more heparin, or we do more strong antiplatelet therapy? What should we do to prevent that kind of complications?
I think not much thing can do. Even you use PCSK9 statin, all the study it just show that it reduce the length of the lesion, but it will not reduce the thickness of the lesion. Most of the case like this will not have problem, but once the lipid-rich part is large or the length is more than 13 mm, then the chance of no refill will be very high. Someone said you should use filter wire and then can prevent the no refill, but Japanese had done the study and they used filter wire. They found that not all the situation can prevent no refill, maybe just less than 50%. So don't think filter wire will work for this situation or drug. Do we still need to keep talking? And then is your PCI strategy. Always remember one step think forward, one step think backward. You have this experience, you know no refill can occur, then you need to think about the solution. Yeah.
Okay. Sorry to interrupt, sir. Sorry to keep you back. I hope this is the last case. And my name is Simon Low. I'm from Penang, Gleneagles Medical Center or Hospital. It is about the worst nightmare that you can get in your whole career as a cardiologist. So this is what it's all about. Doesn't matter how good you are in interventional cardiology, you will get complications if you do enough cases. And as we get along with our career, we become a bit more daring, you know. We take on more and more challenging cases. And this is such a case, okay? Now, what a day. It was pouring. It's blood. Okay? Very quickly, to summarize, this was a 75-year-old woman who weighed only 56 kilos. But she has 20-year history of diabetes and hyperlipidemia and hypertension, and angina in 2008, and the positive stress test, strongly positive, but still good LV function. In 2008, she had an angiogram that showed LAD 80%, proximally, distally 90%. Circumflex also significant in the mid to distal circumflex 90%. And cipher stents then, my era started, and the cipher stent was implanted to the proximal LAD and distal LADD, as well as the circumflex. She remained well, and unfortunately or fortunately, she defaulted clinic, never turned up to clinics until November 2016. That's 8 years later, okay? Complaining of angina, and all her risk factors were not perfectly controlled. Again, stress tests become positive in stage 2. And she was advised to have an angiogram, November. That time I saw her. And this time, it shows an osteo LAD lesion, mid-circumflex, same 80%, before the previous stents. But there was the stents previously implanted, cipher, showed no significant in-stent restenosis. RCA was okay. She was advised PCI then because of the symptoms and the strongly positive stress test, but she declined. And she also sought other opinions, and she was even advised to have CABG, but she declined. Now, she returned the following year, 6 months later or so, on the 16th of April in 2017 when I saw her, and she had significant angina symptoms for about 2 months. LV function was still okay at 55, and the risk factors have improved somewhat. On the 17th of April, she agreed for an angiogram with a view to an angioplasty. And this was the angiogram procedure which I started after clinic at 5:45 p.m. And you can see here, she clearly has osteo LAD disease, and the mid-circumflex disease have deteriorated, and the deterioration was just before her circumflex stent previously. So the circumflex was promptly treated, okay, after I've explained all the features and findings to the patient. So the mid-circumflex was stented with a DES. Then we move on to the LAD, osteo-LAD disease. It was initially dilated with a semi-compliant 2.5 balloon followed by a NC 3.6 millimeter to 24 atmosphere. And the osteo-LAD lesion looks slightly better, but it recoiled rather quickly. And you can see in the bottom that the stent of 3.5, 18 millimeters was unable to cross the lesion. So I have to dilate the lesion again, and this time using a bigger balloon, a semi-compliant balloon, longer and up to 12 atmosphere. Longer, I thought I have to stent into the left main anyway. I might as well smoothen out the tunnel and see whether the stent can go up. Unfortunately, the SEM stent 3.5, 19 or 18, 19 could not cross the lesion. Okay, so twice I failed to cross the lesion. Now, what else can I do? I put an anchor balloon in the circumflex, which already had 2 stents by now, and surely the stent advanced, okay? And I deployed the stent, okay, to a 16 atmosphere. On the chart, it says 3.75 millimeter in diameter. Now, this was the result after my stenting. Now, I put down in red color there. That was what was in my mind when I saw this picture. I need to post-dilate this LAD, osteo-LAD especially, and then I will do a pot in the left main where the stent will be jutting in, okay? Now, can I ask the panelists, would you do a post-dilatation? And would you also do a pot in this lesion? Or would you say, okay, it's already 6 o'clock or 6:30, I want to go home? Would you leave it like this? Or would you do further improvement to this osteo-LAD? You would carry on and do what I have in mind? Would you, Dr. Lam Ho?
Depends on the IVUS. If it's not good, then may do something.
This IVUS thing, our friend there also said not everybody can afford an IVUS. In this case, we already have a deal, you know, in the beginning. We will keep the cost to the minimum. Okay, so I look at it. I use my EYE IVUS. I look at it. I say, well, there is a problem there. It was very hard. Even the pre-dilatation showed recoil very fast. They must have some calcium and fibrotic tissues there. So I decided I have to post-dilate. So I put a 4.4 times 6 NC balloon to post-dilate the osteo LAD. I didn't go up to high pressure. I just went up to 12 atmosphere. In the chart, it says 3.9 millimeters. After that, I need to go and do a pot inside the left main stem. Okay? And what happened to the pot? Oh, can you, let me see. Can I run this? Can you help me to run these angiograms? Oh, hang on. Maybe. Okay. I can click here. There we go. That was when I was positioning the balloon for a pot. And this was what I saw. And can you imagine? It's already 6:30 or something p.m. And I thought I could go home. Okay? So as I was positioning this 4 balloon for pot, I saw a huge, okay, at least you can say type 3 or class 3 perforation of the proximal LAD. Okay? And so I was thinking, well, it's just a perforation. So what? Okay? So I asked for a stent graft from the lab people, the technicians and the nurses. And what was the answer? No, we don't have one. There you go. Okay? Now, I was shocked, you know. And what was the reason there was no stent graft in the hospital, in the lab? Why? Because of the recent hospital accreditation for JCI. And anything that is expired must be removed from the lab and the hospital. So we always have 2 stent grafts, but it was expired, so they were removed from the hospital because of the hospital accreditation. So I have to say at that time I wasn't very happy. So I have to tell off the cardiac manager and tell him, you have to get stent graft for me from the hospital's in Penang Island. So he started calling up all the hospitals. But bear in mind, that was already 6:30 p.m. Everybody have gone home, okay? And not many people were left behind. So he has to call some people at home even to get some ideas about where the stent graft are. Anyway, other cardiologists have also left the hospital. Only the anesthetist on call was in the hospital. But anyway, I said, anybody, ask them to come. And the cardiac surgeon also has gone home, but he said he'll come in and have a look. What do I do? Well, this is the acute complication of a PCI, a main vessel perforation. And you can see here, this was my problem, main vessel perforation. It's not a distal vessel. And this is the algorithm for treating coronary perforation of the main vessel. And it's universal that we have to inflate the balloon to occlude the artery, and then we may have to give some IV infusion of fluid to help to push up the blood pressure and carry out pericardiocentesis if necessary. I've already informed the surgeon and looking for a cover stent. So this was what I supposed to do to follow the algorithm, and 4.6 millimeter balloon inflated, and not at high pressure, low pressure, 7, 8 atmosphere, trying to block this perforation. But you can see on the angiogram, there was still a leak, despite the fact that I inflated a 4 balloon at a 6 to 8 atmosphere at the site of lesion. So something is not right with this artery. And because the patient could not tolerate this long inflation, after 1 minute, she complains of angina. And you can see the ECG changes and so forth. Okay? And she'll be screaming about pain. And I have to deflate the balloon almost every 2 minutes for 10, 15 seconds to allow some degree of, perfusion and reducing her angina. And I went on like this for about 20 minutes, and then her blood pressure started to drop. I was still shouting for a stent graft, okay? But of course, cardiac manager has gone out to another hospital. Another person has used a motorbike to another hospital to get this stent graft for me ASAP. And at the same time, because the blood pressure was, coming down, I have to prepare the patient for pericardiocentesis, okay? And 28 minutes later, for some reason, if you look at these 2 angiograms, has the bleeding stopped? It looks as if the bleeding has stopped, But maybe the one in the bottom, the spider view, may not have stopped completely. I get still a little bit of a flush, But I think actually it appeared like it has slowed down because of tamponading, because of a cardiac tamponade. A BP has dropped now to 90. Echo effusion now is 12 millimeter instead of 9 just now. And I already have taken out 150 ml of blood from the pericardial space. The inotropes have been started. 34 minutes after perforation, luckily, the graft master in 2016-17, it was a graft master a lot of hospitals have, okay, arrived. So we have a 3 millimeter, a 3.5 millimeter graft master. Pericardiocentesis has to carry out, blood pressure improved to 120, but there you go. I had a graft master here in this guiding catheter, and I could not deliver this graft master, okay, even though this is 7 French guiding catheter. And her blood pressure suddenly crashed to 60. Basically, she arrested, okay, at 7:20 p.m. I spent about 4 or 5 minutes trying to get this graft master in. Obviously, during that time, I wasn't doing the ping pong technique. I have nothing to block the leakage, the perforation. So she may have accumulated a lot, and she developed asystole, and we have to carry out CPR on her. And worst comes, bad things come in not in single hand, but 2 hands. The wire and the guiding catheter all drop out during the CPR time. Okay. However, we managed to reestablish her rhythm. Her blood pressure improved on inotropes to 95, and also continuous aspiration of the pericardial effusion. A 7 French guiding catheter I want to put back, but could not re-engage in. So I have to use a diagnostic catheter, 5 French, small catheter, to get into the left main stem. And I did 1 shot. What happened? I think there are lots of clots, but there's no flow in the left main stem, as you can see in the bottom angiogram. Okay, I think there may be a lot of clots. The expert panelists will see this, and I'll let you have a look at it a few more times. Is it clot or is it something else? You see? Okay, no flow. Anyway, I managed to wire down using this through this diagnostic catheter. I put a wire there and then extension wire. I managed to exchange this catheter into a AL1 guiding catheter slowly. Okay, and then through this guiding catheter, I managed to put a balloon there and dilated the left main stem. Okay, and after I dilated the left main stem, the flow was re-established about 7:45 according to the recording. But I wonder whether there was a dissection in the left main stem. Okay, it may be due to manipulation of the guiding catheter and so on. But unfortunately, the leak was also re-established. And then pericardial drain, another 120 mil. Okay, finally, the graft master 312, okay, managed to cross, and I deploy at 8 p.m. And this graft master is really an awful master. Okay, it took a long time to deploy the stent. In fact, it took over 1 minute, okay, for the stent to expand, and eventually I managed to bring it up to 20 atmosphere in the proximal LAD. Now, you may look at the picture and you may think that my stent may be too distal. The proximal dot of my graft master is actually probably at the site of perforation. But actually, before I deployed this, I did manage to pull back a couple of millimeters or so, and then only deployed. But after I deploy, because I think I have to inflate the balloon for over a minute to get to 20 atmosphere, the patient rearrested. Okay, and we have to do the same thing, massage and massage. Okay, and after massage, with someone else's hand also, never mind. And you see, there's a finger. I think that's a ring. Okay. Moving there, I did a shot in the left main. I think there is actually a dissection of the left main. You probably can see now quite clearly the dissection. And it's still leaking blood from the perforation site. Terrible, okay? And I just also wonder still whether the stent graft was too distal still. Anyway, I put another stent in, DES, 3.523 now, from the ostium of the left main, again, to cross over, to overlap with the stent graft into the LAD, okay? And then I post-dilated using an NC balloon 3.5 from the left main stem all the way to the almost the mid-LAD, all up to 22 atmosphere, okay? Now I feel a bit better, okay? Because now it looks okay. Never mind about this circumflex, I said to the nurses, I remember. We have to save the LAD, okay? And you can see there's a little bit, still a bit of function there, pumping action there in the LAD territory. I said, never mind about the circ, we just wasted the circ, it's okay. And IABP was inserted, and the patient, anesthetist was there during the resuscitation. She was already ventilated, and we transferred her to the ICU at 8:45 p.m. I'm supposed to be hungry that time, but I wasn't really hungry, you know. On ICU, on low dose of adrenaline and noradrenaline, her blood pressure was well maintained though at over 120. She was responsive mentally, you know, and she had a few runs of self-limiting VT, and however, this echo you can see there, the pericardial drain continued to have blood, okay? And the echo showed this persistent pericardial effusion, and I wonder whether there's still a leak, you know. It's basically like pouring blood out from that somewhere. So I decided to take the patient back 10:30 p.m. to the lab. What happened? I did semi-emergency angiogram. I did one shot, first shot, and the patient developed asystole. Okay? And we have to do CPR again. Okay? And luckily the CPR was successful. Okay? But can you see the leak coming out again? Yeah? Can you see the leak coming out superiorly, just underneath the pigtail? Yeah? Now, I am stuck, you know, and What should I do next? I've already implanted 1, 2, 3 stents, almost 3 stents already in the left main to the LAD. And it's already almost 11 o'clock p.m. Okay? Anyway, this cardiac manager managed to get 2 stent grafts over. One was 3, the other one 3.5. So I managed to get the 3.5 in and really just put the stent graft in the left main at the bifurcation, into the LAD. And I post-dilated again using the same 3.5 NC balloon, this time to 24 atmosphere, okay, slowly. And I tell you again, the stent graft is such a bad stent. You know, it took a long time to inflate and deploy it. Finally, I thought I have achieved successfully, there's no leak, okay? That's what I thought, okay? Anyway, the bleeding stopped. Actually, she had a stormy recovery course that night. She had VT attack, overnight and the next day, and was cardioverted 157 times, okay? I have to say the first 10, 20 times I used the defibrillator pad to put on her chest to shock her out of the VT. After that, I just put the defibrillator sticker pad on the chest and just press the button. And I keep telling the nurse, press the button will do. Each time she gets the VT. Did not respond to lignocaine, amiodarone, or magnesium. But finally, the next day, lunchtime, I managed to convert her or stabilize her using intravenous calcium. I didn't know that. In fact, it was a long shot in the dark. I said, just give her some calcium and see. Wow, the calcium actually stabilized her VT, okay? And I did an aortogram and angiogram, and you can see, okay, I did an aortogram just to have a look at the right coronary artery, and I selectively intubated the left coronary, and the left coronary now looks okay. And the echo, you can see now, got no pericardial effusion, okay? 4 days later, I removed the IABP, but her BP was maintaining on the 2 inotropes. However, 6 days after all this, she desaturated. And the x-ray showed consolidation. The hematologist was helping me to look after her because the platelet count was dropped. I don't know whether it's because of auto transfusion. I took out some of the pericardial blood, injected into her vein. I don't know whether that's the reason for some hemolysis and some low platelet count. Anyway, she became septic. White cell went up, fever, BP dropped, and she needed more inotropes. And then, unfortunately, about 2 weeks after the angioplasty, the ordeal of angioplasty complications, she developed multi-organ failure, renal dysfunction. Actually, she passed away about 2 weeks after the PCI. So, sometimes you can save them all. Most of the time you save them all. Rarely, occasionally, you may lose a patient. So, my take on these PCI-associated complications. Most frequently, the beginning of the procedure is the end also of the procedure. Extremely rarely, we hope rarely, the end of the procedure is the beginning of a very complex procedure. And this case illustrates this definition of what I meant by PCI-associated complications. So, just for discussion's sake, I look back on this case. I will never forget such a case, okay? What did I do wrong? Or what haven't I done? What have I forgotten to do? What should I have done, if I were to do it again? What else can I have done? You see? What about the initial preparation of the lead? In fact, I think the best thing is, I put this slide on the, maybe we can just discuss with the panelists and the audience about some of these points that I have made here. Should I have performed a proper IVUS, IVUS, rather than just using my eyes, my own IVUS, okay? And the graft master, luckily, is no more. We've got a better stent graft nowadays. And, and I said to the lab people, even an expired cover stent can save life. Don't throw them away, okay? And this graft master will, Anyway, my last slide was to tell you there is no greater danger than underestimating an opponent. And this is the famous Chinese Lao Tzu, okay? in his war strategy. So be prepared. Okay. Thank you very much.
Thank you so much, Dr. Lam Ho. We can share with the very tough case, and there are a lot of feeling. But I think we can learn a lot of the educational information from the case. And I can also thinking about very strong message from you. It is a never give up. But it is very interesting case. So may I ask our panelists have any comment or questions?
We always, it's like this, is a French philosopher, Voltaire, is, the best is the enemy of good.
So what would you have done? Would you have actually tell the patient, I must do an IVUS?
No, in fact, it's not essential. If you see the new score absent or the person or absent of IVUS, just 0.5 point only. It's not that important, but it's no matter IVUS or angiogram, you will see some imperfect result. Sometimes, if we do not pursue for perfect, then maybe.
Do you think otherwise, do you think I should have done a CT angiogram, CT coronary angiogram first?
Yeah.
Because, the artery was so, but then,
Really-
he already has a strongly positive exercise stress test. I mean, I do a CT angiogram, usually if it were a CTO, you see, yeah.
And in this year, in TCTAP, I see one Singapore doctor present one similar case. They don't, I can't remember why they don't have the cover stand. They put 3 megatron, and then 3 megatron in the proximity, and then seal the perforation.
Yeah,
While
3.
3.
I really don't understand why was it so difficult, because, I actually put 3 stents in. Maybe I was guessing, in fact, I look at this angiogram probably about 50 times, 2 views. Did I miss the proximal? Did my graph master too distal, that it did not fully cover the perforation? But I did pull back. I remember I pulled back, but I didn't see any it. Okay, I know that there was one shot I did. The perforation, was actually not completely covered by the stent, but I pulled back. A couple of millimeters. I should have covered. But this. Then I found out this graph master actually, the struts. You see, there is a cover portion up to 1.6 millimeter from the stent edge. So actually, your stent edge is not covered.
Yeah.
Only 1.6 millimeter inside the stent edge, then you see the cover. Okay.
Yeah.
So even if I pull back 2 millimeters, I'm just show this. Afterwards, maybe that's the reason why it was not fully covered, because the stent graft is so badly designed that there's a big gap, 1.6 millimeter between the 2 ends of the stent and the graft.
Yeah, and for graft master, is out of market now. Also, doing high pressure ballooning, while you expand the graft master,
It
then you
shortens.
have foreshorten, 20% foreshorten in the.
It probably also foreshortened by 5-10%. Yeah, good point. So, yep.
Dr. Simon, very exciting presentation actually. I just mentioned that you're waiting for so long and that the 2 graft master to come to solve the problem. But at the beginning, you use the JL guiding catheter. You use the guiding. At first, you use the JL guiding catheter.
Which JR?
Yeah, JL.
You mean put another
Yes.
guiding catheter?
No, because I asking you about why the graft master cannot reach the destination, because maybe the guiding catheter or because what's the reason? According to you, what is the reason?
I
We've
wonder,
been waiting for so long, so we want this come to the destination as fast as possible.
Yeah.
So now it cannot go in the position, so it still take more time. I think.
This graft master, the profile is so bad, so big, that when I have put stents in, when I try to push the graph master in, the guiding catheter comes back because I think the graph master is so big, the profile is just scratching, hitting the struts of the previous stents inside the artery. And so it refused to go in. Of course, nowadays we have a slightly better technique. If we got a guide extension, we can introduce the guide extension in, yeah, and then deliver the stent graft or guide master, whatever, and then pull back, expose the, pull back on the guide extension. That night, everything could go wrong, went wrong. Yeah? You know, it took such a long time even to deliver a graft master. Partly also because my fingers may not be so good that night as well, you see. Sometimes we have bad days. Occasionally we have bad days. We hope it doesn't happen often. Yeah. Really because the graft master was so big in profile, and I have a 7 French in, and I was trying to put a 3.0. I know their guideline is if it is 3.5 or less, you can use a 6 French. You can use up to 6 French. If it is more than 3.5 or 3.5 or more, you must use 7 French. Okay, and I had a 7 French. Okay, and a guiding catheter, and it still could not support my graft master. I think actually the previous stents, struts of the stents inside the artery and the left main has provided some hindrance for the forward movement of the graft master. Yeah, and that delayed me a lot because I don't have another guiding catheter for the ping pong technique, you see. Or if I have an 8 French, I maybe put another wire in and therefore another balloon into the LAD and block that first, and also serve as an anchor balloon whilst I advance the graft master. But that requires at least an 8 French guiding catheter.
Thank you, Dr. Simon Lo. So I think it's a very interesting session. So because of time, so we have to stop our session right here for the next session. So again, I would like to thank for our 4 very excellent speaker, and also would like to thank our co-chair and our panelists here. So I think we have to close our session here for the next session. Thank you so much.
Thank you. Thank you very much.
Xin quý vị đại biểu cùng sẽ cùng nén lại và sau cái